Welcome to this show discussing problems and issues of health with Dr. Alcena. When I left last week, I was talking about diabetic ketoacidosis, which is a very serious medical emergency. Diabetic ketoacidosis comes about because of several reasons. Number one, of course, is individual can have an infection such as urinary tract infection, pneumonia, or the patient may have a heart attack, and or somebody who's an alcoholic may become drunk, become agitated, and these conditions cause the individual to over-secrete adrenaline and cortisol. When those two hormones are in high quantity in the bloodstream, they completely negate the effectiveness of insulin. Insulin simply will not work in this setting. So therefore, the patient then starts using fat as a source of energy because the number one source of energy we have as human is glucose. But if you can't use, if insulin will not work, therefore you cannot use the glucose, the body may, in this case, try to use fat as a source of energy. Well, that's a terrible source of energy. When you start using fat as a source of energy, you're eventually going to have a lot of breakdown product of the fat. Those are called ketone bodies. And the ketone bodies then can cause a lot of symptoms when they're piled up in the human bloodstream, such as nausea, vomiting, headache, a smell of fruity smell like in the mouth, and the patient then become confused. And then, of course, you examine the blood sugar, it will be between 300 and 500 thereabout. That is the blood glucose. You check the urine, you'll find a lot of ketone bodies on the urine. So, and then you do a metabolic profile, you find that the patient will be severely acidotic. That is, the bicarb is very low, and it's very low, and the potassium is very high, and then you are in deep trouble. Your electrolyte is completely out of whack, and then the patient is getting more and more confused, and this patient needs immediate medical care in an emergency setting. This is not something that can be treated in the doctor's office, has to be treated in a hospital, and the first place in a hospital for treatment to be given to such a patient is in the emergency room. Once the treating physician recognizes the problem, he and she will come right in and get the patient. You do your chest x-rays to look for pneumonia, say urine culture, you could check the urine, see if the nitrate. If the nitrite is elevated, that indicates there's an infection. It can take you a long time for the urine culture to come back. But if your nitrite is positive, that indicates there's a urine infection. Yes, you could have a urine infection with negative nitrite, but that's usually not the case. Usually the nitrite will be positive, so you could find out about that quickly. Pneumonia, you could show that in the chest x-ray. You do a blood count, the white count's going to be high, you're going to have a shift to the right, combined with a shift to the left, etc. So there are ways of telling if there's an infection. Once you do that, then the patient has to be given, place an IV fluid in the patient. You make sure you get your troponin, get an EKG to make sure there's no acute heart attack going on. You get all that done, and then you have to quickly start giving this patient insulin. And the insulin has to be given not subcutaneously, because the patient may not be perfusing properly. You can't miss. That's where the insulin is going to be given via an insulin pump. You put an IV in, and you're going to give the patient 20 units of regular insulin to start right there. Once that's on board, because you really have to quickly get this patient to start using glucose. Quickly get the patient to start using glucose. Once you get your first dose, 20 units of regular insulin, then you continue your insulin pump. The patient is getting regular insulin for the first 24 hours or so. The patient, you're going to have to control the situation by giving the patient a lot of normal saline or half normal saline, depending on the individual patient. Then make sure your electrolytes are in good shape. If the potassium is very high, then you're going to have to give the patient an amp of bicarbonate acutely, and also add bicarbonate to the IV fluid that you're giving the patient to bring the potassium down, because you can't afford to have high potassium because that can cause severe cardiac arrhythmias, etc. You look at the renal profile to see what's going on. Is the BUN up? Is the creatinine up? All these things have to be taken into consideration. And then once you stabilize the patient, Okay, the very next day that you brought the blood sugar down, you have to change the IV fluid. Absolutely, you have to change the IV fluid. Now you're giving a patient IV fluid with sugar. That's right. Yesterday you were trying to fight to get the sugar down so that you could get insulin so that the patient can use glucose. The next day, now you have to restart the IV now with sugar in the IV. Why? Because now you have insulin. Once you have insulin on board, you need not to be afraid to use glucose because you need your patient to be in an anabolic state. When you're not using insulin, the patient is catabolic, breaking down tissues. You want your patient to be in an anabolic state. The best way to do so is to give the patient glucose. That's the best way to do it, believe me. Give the patient glucose intravenously with insulin, regular insulin. Once you got the situation completely stabilized, the patient is no longer ketonic, you control the electrolyte situation, all that is under control, then you're going to have to set up a plan on how to go about figure out why this happened to the patient. If there's a pneumonia, you treat the pneumonia simultaneously. There's an urinary tract infection, you treat that simultaneously. And you cannot wait for the result of the microbiology to come back. You must know enough clinical medicine to know which antibiotic to use broadly. That's going to cover for gram-positive, gram-negative, and anaerobe. You must know these things. You can't take a guess because you cannot miss. You cannot miss. You can't, and you have to be right. I know no one is perfect. I'm not, but you cannot be wrong. You must be on target by knowing what broad antibiotic to use, depending on what it is, what the infection is, what are the conditions the patient may have that may have led to this particular situation. So once you do that, your patient is now stabilized. Your patient is now getting regular insulin. Your glucose is under good control. The urine no longer shows ketone bodies. The patient is no longer acidotic. Then you're going to have to step in by using NPH. That's right. NPH is a long-acting insulin. Okay, you usually start with 30 units of NPH in the morning with the patient with breakfast. That's the first day. You still have your regular insulin going on because you have a setup so that the blood sugar is being checked every 4 hours or so, and the nurses have the orders how much insulin to give based on how high the glucose is. That's setup. That's a regular setup in all hospitals. So you don't have to worry about that. But however, because the long-acting insulin is not going to kick in for some 8 hours, okay? The short-acting insulin kicked off within half hour and stop working 4 hours later. That's how regular insulin works. So now that you're going to set your patient to set up a long-term treatment for this patient now, okay? Okay, to put back on whatever he or she was on before, what was going on, was the patient taking oral agent? All this stuff has to be taken into consideration. If you don't know how to do this stuff, you must get yourself assistance from an endocrinologist that can come at the bedside and help you. You cannot mismanage this patient. You just cannot. And if you don't know much about electrolyte management, you must find someone to come and help you. Once you get this going, then of course you're going to have to plan for the patient to get diabetic education. There are nurses that do that. The hospital have plans of different outpatient people that do discover diabetic education so that this doesn't happen to the patient again, because the patient could have died. So you set up all that stuff and you set up a plan, a treatment plan for the patient. Namely, you're going to give the patient long-acting insulin and regular insulin. The patient can be discharged with those. With breakfast, the patient can have 30 of NPH in the morning with 10 or 5 of regular, depending. And then nowadays, they have all sorts of machines that people can use to test their blood sugar without even sticking themselves. So your doctors will tell you which one that's best for you, which one your insurance company will pay for, and so on and so forth. I'm not naming anyone in particular because I'm not here to sort of tell people what to do, what to buy. I'm not endorsing anything. I'm not here to endorse anything. So once you do that, then you have to try to educate the patient so as to prevent what just happened not to happen again. because sometimes these things happen not because of an infection, not because of alcohol problem. It's because the patient didn't use the insulin. Sometimes they just don't have the money, and they're trying to ration the amount of insulin that they have because insulin has become extremely expensive. I read a couple of weeks ago that some people are paying $450 a month to get the supply of insulin. $450 per month. Okay, now most people cannot afford that kind of money. It's a lot of money because they have a lot of other things to take care of. They have to pay rent, they have to buy food, they have to buy clothes, they have to feed their children, they have to put gas in the car, they got to go to work, they have to pay for the subway, the bus, whatever. It's a lot of money. And then they have other conditions. It is not frequent that diabetic is just by itself. Usually diabetic is an association with hypertension. It can be an association with high cholesterol, the so-called metabolic syndrome. It is not always that somebody just have diabetes. Frequently, it's an association with other condition that's also you have to pay to buy this medication. It is very, very expensive. Medical care in this country is a very expensive process, super expensive, super expensive. We're talking about a $3.2 trillion business. They're supposed to go up to 3.5 trillion this year. And as I mentioned in the show last week, it's been discovered that $950 billion, $535 billion are wasted on necessary things that are done in this country in the practice of medicine. Okay, the healthcare system, not just the doctors, a whole lot of other stuff. $935 billion that are wasted, okay? And then yesterday I read $880 billion that doctors and other healthcare activities are wasted every year through the process that you have to go through to get things approved. You have no idea. It is catastrophic. Hours and hours that you have to spend on the telephone arguing, fighting, literally arguing for patients to get medications approved for them, to get tests approved for the patient. The HMOs made it literally impossible. They do that on purpose to block you from being able to get stuff done for patients that are in need of these things. $880 billion of time wasted in this particular process. And these people have so much power. They have so much political strength because of the lobbies. There's nothing doctors can do, nothing hospital can do. They have to find a way to get this stuff done. Because when your patients need it, patient need a CAT scan, patient need an MRI, patient need a colonoscopy, endoscopy, all these things have to be done because the doctor have decided these things are necessary. Patient needs certain medication, you have to call, and the most frustrating part of it, you don't even get to speak to a healthcare professional most of the time. You get to speak to someone who doesn't know what it is that you're talking about. To try to get in touch with the medical director to talk doctor to doctor, which the New York law allows you, is a big deal. Take hours if you're lucky. It is a very complicated process, and all these things that I mentioned has nothing to do with the actual care of the patient other than to put block in your way for them to save money. That is all it's all about, is to save money for themselves and the shareholders. That's it. So diabetic ketoacidosis then is a serious, serious medical emergency that must be dealt. The first of all, that must be recognized, and that must be treated immediately. And the thing that the public must do is to try to avoid that. Diabetes is a serious medical condition. When you are diabetic, you have to understand that you are diabetic. There's certain things that you don't do. You have to be very careful so that you make sure that your blood sugar is in good shape. Unfortunately, there's major disparity in the field of diabetes itself. I brought this paper here to show you so that you understand the ethnic disparities. I have here 13.6% black folks in this country have diabetes. 10.9% Hispanic have diabetes. 9.9% Asian have diabetes. And in terms of white folks, 9.1%. So the people of color have the highest incidence of diabetes in this country. Okay, and I'm here to tell you, genetic may have nothing to do with it. Genetic may have nothing to do with it because it's only a percentage of diabetes mellitus is the result of gene transmission from parents from all offspring. The rest of it has to do with the things that are happening in the environment, such as obesity. You cannot be obese, and of course, obesity is an epidemic in this country. Of all the developed countries in the world, there are more obese individuals in the United States of America than 80 other developed countries. All you have to do is turn on the television. You see the incredible amount of things that are being advertised. All of them are unhealthy food that are being advertised. People are being bombarded with all that stuff. And 100% of them are unhealthy food. They're bad for you. But the circumstances of life is such that some people, that is all they can afford. Even though the food is bad for them, when you're hungry, the pain of hunger is nothing to play with. And I'm not just talking about the pain of hunger as a physician. I experience what it is to be hungry with a serious pain. Okay, so people eat that which they can afford. That's it. It's okay, but it is my responsibility as a physician to talk to my patient to try to explain to them how dangerous it is to be obese. Obesity is not an aesthetic thing, it's a serious medical problem. You cannot be obese, live long enough, don't ultimately develop type 2, what I call type 3 diabetes. It's inevitable because when you are obese slash overweight, the pancreas is sensing that you need insulin downstream because and when the insulin gets into the bloodstream, because of the fat cell cannot penetrate them. In the meantime, there's a need, the pancreas is sensing there's a need, so it kept pumping more insulin down in the stream. Well, the pancreas, all of us were born with the exact amount of beta cell in our pancreas. That's it. Once you use that, you can't replace those unless you were to do a pancreatic transplant, which has not been successful yet. So therefore, as you keep pumping more and more and more, eventually the endocrine part of the pancreas become exhausted, and you develop type 2 diabetes, or what I call type 3 diabetes. Because type 2 diabetes is diabetes that's basically you inherit via several genes that you can, any one of them can cause you to develop type 2 diabetes. If you abuse alcohol and you develop acute pancreatitis recurrently, subsequently wind up with chronic pancreatitis, it is inevitable you're going to become diabetic. Because once the pancreas is damaged, eventually the endocrine component of it is going to be destroyed and you become diabetic that way as well. Okay? You have hemochromatosis. Look at how many billion people in the world have secondary hemochromatosis because they have hemolytic disease or they have rheumatological problem that cause iron to pile up in the body. Well, some of that iron is going to be piled up in the pancreas. Once it is piled up in the pancreas, wherever that iron is piled up, it must degrade. As the iron is degrading, it's going to release free radical. The free radical in turn sends out, it causes an inflammatory reaction to develop. That inflammatory reaction eventually damages, in this case, the pancreas. and you're going to develop diabetic. You're going to develop diabetes that way. I can go on and give you all this incredible example on how people develop diabetes. So, diabetes mellitus is not just the one that you inherited genetically from your parent. There are all of other conditions that can cause that to happen. So this is why diabetes is so common. In this country, there are 30.3 people who have the so-called type 2 diabetes. 100 plus million have the so-called pre-diabetes, which as I mentioned, doesn't really exist at all. Okay, and I've gone through that already. I'm not going to bore you with that again. So therefore, then you must do everything you can to stick with the medications, the diet that the doctors outlined for you, the best you can. Believe me, the best you can. I know. I know it's not easy. The poorer you are, the more problem you're going to have with your diet because the diet that are good are very expensive. When you live in a developing world, yes, there is poverty, but people also can have access to stuff in the countryside. They can grab a mango. They can grab a banana. They can eat some sugar cane. They can eat some other fruit, yam, potatoes, plantain, all these things. They can eat these things. But when you're here, yeah, you could find these things here too, but you got to pay for them. You have to have the money to pay for them. But when you're in the developing world, you could go in the bush during the mango season. The mangoes are dropping all on the floor all over the place. You grab all you want, and so on and so forth. So you could eat oranges, all these things. So all the good diets are super expensive. And you have to have money to buy them. You can't just walk in the store and get this stuff. You have to pay for it. And if you don't have the money or you're living on a limited income, and most these people are living from paycheck to paycheck. So therefore, that's the problem. It's not, poverty is nothing to be ashamed of, but poverty is a serious problem. You just got to do all you can to work yourself out of it. And the only way I know how to work oneself out of poverty, in addition to going to work, 2, 3 jobs like I did, is to go to school. These people have incredible potential. You have no idea how intelligent some of these folks are. But they need the discipline so that they can go to school or learn a trade that will allow you to get a job because you have a skill. You have to have a skill. You have to have a skill. In this country, and this is a fantastic, great country, people will help you if they see that you are intelligent. If you have brain power, people will extend their hand to you. You can't just have a culture that deals mainly with sport, music, and the young people are growing. That is all they see. Everybody who's into the sport world, they turn them into hero. Everybody who's in the music world, they turn them into. So that's why these people are looking up to. But if you become a physician and you have brain power, nobody is going to turn you into a hero. Not that I want to be one. If anything, they do all they can to knock you out because they don't think you belong. Even though they don't know half what you know, but they still don't think you belong, okay? So all I can tell you is the fact that if you just keep your children in front of the television watching sport, and that's all they see as a role model, things never going to change. It's never going to change. It's going to remain the same. And if anything, it's going to get worse. And it is getting worse as I speak. But if people go to school, I mean, when I went to college, I worked 3 jobs, and went to college, okay? Because I knew that is all I came to this country for, not just to work, but I came to this country to go to school to educate myself. I had no idea. I didn't even know how to spell the word medical school. And I wind up in medical school because I went to school. The school enabled me to have the skill that I needed to do what I did that got me to medical school. When you watch television, you see all these tech commercials that are selling Humira and all this other stuff. I didn't do the Humira, but I did the original research using methotrexate that turned into all that you see on television, which is what got me. That's the research that got me into medical school. That's the first research that I ever did on my own, from the top of my head, using the medication called methotrexate at Brookdale Hospital in New York. Okay? That's how I got into medical school. And since then, I have done things without bragging that are helping hundreds of millions of people across the world. Okay, that's how I got to be a professor. That's how I got to be an M.A.C.P. I applied for the first time as an M.A.C.P. Nobody said, Val, apply. I just checked. I said, Jesus, I think I'm qualified. Why don't I apply? Okay, and I did. My resume was 19 pages, and I needed a couple of sponsors. That's it. The next thing I know, I became an M.A.C.P. because of all the stuff that I did. It was all there. It was all verifiable. So, and who would have thought a young person like me who almost starved to death when my mother died when I was 7, growing up in the peasantry of Haiti, and here it is, I'm sitting here, one of the leading doctors in the world, right? That's right, one of the leading doctors in this country, that's right. Because America allows me to do that. Okay, so all I can tell you is that you go to school, you work hard, you will be rewarded. Nobody can stop you once you have brain power, as long as you discipline yourself. So, getting back to diabetic ketoacidosis, then you got to follow the advice of your doctor, do the right thing, take your medication, be careful, and then chances are you will avoid finding yourself in diabetic ketoacidosis, which could threaten your life. Okay? You're diabetic, you have to understand you have to live your life in a certain way. Pay close attention. And next week, I'm going to begin to talk about the other serious problem the one can face when you're diabetic. Is, of course, is the so-called hyperglycemic hyperosmolar syndrome. I'll be talking about that next week. Until I see you again, this is Dr. Alcena saying so long and bye-bye.